It's about a 62 years old. He has diabetes and hypertension, dyslipidemia, and he's a former smoke. He has the whole package for, how can I say, the risk factors for coronary disease. October from last year, he presented with a acute coronary syndrome. So since then, he has been with some angina class 2. So he's doing medication. He's taking aspirin, clopidogrel, atorvastatin, losartan, amlodipine, Diuretics, and atenolol for since the event. Since then, he just made a nuclear study in January this year, which has a rest improvement of perfusion in anterolateral wall of left ventricle, and he has a persistent low uptake in the introseptal wall of left ventricle with the preserved function.
Okay.
So it's the right coronary, so you can see, appreciate. So there's two focal lesions in the proximal and the mid segment of the right coronary. It's a dominant right coronary. Yes.
Let's go to the left system, please.
So the left system, you can see there is there's the circumflex. That's, I think, is the most severe lesion.
Now, and then, how about the LAD, Louis?
Yes, the LAD. So in the cranial view, you can see it's a very severe lesion.
Okay.
There's two lesions now on the circumflex, and there's the
A normal LV
normal
function.
LV function. That's 28.
So just to summarize, but we have a triple vessel disease, two lesions in the right, two lesions in the right, two lesions in the circ, and two lesions in the LAD system with diagonal. So we have 6 lesions
Yes.
in this patient.
Yes.
So here we are in the distal reference of the circumflex, and you can see this is a vessel about 4.0 reference diameter, lumen diameter. Next one.
Já vai trabalhando.
This is the small lumen area for the distal lesion. So you see at 2.44, but plaque burden is about 80%. The next one. Here, Fausto, is a very interesting image, and I'm going to ask to play, but you can see, you already start to see the lesion from 5 to 9 o'clock. It's a high lipid core lesion.
So let's move to Angel now and ask Louis what he's doing there. What did you bring? A balloon to predilate?
Yes, a balloon.
375 by 20.
Yeah.
So that's a large vessel.
Okay.
Okay. So Rodolfo prefers to predilate to facilitate the stent deployment. So it's a large vessel after a 3.75 predilatation. And now, what kind of stent did you choose, Louis?
We choose a 4 by 38, 4.0 by 38 length stent. It's
So when are you choosing a 38 because you still have some disease in the proximal part of the wire? Now they are just position, they stand. So the distal flow we cannot see, but seems to me it's in a good position.
Yeah.
Esse é por distal.
There's some dissection there.
Vai. Ok. Menos.
Yeah.
Now we are up to 8
Balão de pulse,
80 atmospheres with 4-0 balloon. There is still some constriction there
No constriction.
in the proximal part of the balloon.
2 milímetros. Então, 10 aqui, pronto.
we are going to postdilate now here.
Postdilate, what balloon did you choose?
We are choosing a
420.
It's a 4.0 by 20.
4-0 by 20, a non-compliant balloon. First in the distal part, just to treat the circ. Let's take the result.
Okay.
Take a look in the result. And Louis and Rodolfo are very careful to place and doing the post dilation. Seems to me it's a good one. Should we do IVUS now just to check? I think and to avoid die. How much pressure did you use in the post dilatation, Rodolfo?
20.
20 atmospheres with a 4-0 balloon by 20.
Here you can see the vessel, which is close to 4.0. You see the distal reference.
Distal
no signs of
transition is good.
dissection. Very nice position. It's a correct landing zone. Great uniform lumen area, as you expect, a 4.0 with.
So can we go ahead and go to the next vessel now, Louis?
yes, I feel comfortable.
Oh, yeah? Let's go. So are you going to work in the
Yes.
in the LAD now?
Yes. we're going to-
Bifurcation.
Yes.
Well, so let's go there. Now they are trying to get get the
These are separate osteons, so that's why you need to.
separate osteon. Huh?
Yes.
He's working with the guiding catheter and with to have the LAD engagement by the guiding catheter.
Pontadora, só para dar um.
Now we have the wire in there. Are you going to do a clockwise or otherwise?
Clock.
Clockwise, but we are trying to, as a separate
Okay,
osteon.
now
Yeah, we
Now-
just engage the LAD here first.
in the LAD. So the LAD is engaged now. And now he's bringing the 14 wires to cross the lesion in the LAD. That's going to help with the guiding catheter too. As you can see here, this is a good maneuver. Bring the 35 wire, orientate the guiding catheter, go to the separated osteon. We are in the circ, now in the LAD. Now we have the 14 wire, go to the cranial view. If you see here, he changed the cranial, and now he's trying to cross the lesion, the bifurcation lesion here.
50 pro diagonal.
It's good to have the reference in the screen, the reference.
Yeah, we didn't, because we didn't already
Okay,
make the angel here first. We're trying to, how can I say,
okay.
save some dye here. Some construct media.
Now the wire is distal in the LAD, the first wire,
Tá bom, hein?
and now he's gonna bring another wire
Tá bom. It's a,
to the diagonal.
yeah,
Yeah.
a polymeric wire.
Why do you use a polymeric wire? To
Retriever.
facilitate. Okay,
Facilitate the retrieval of the.
Yeah, it navigates better in
Yeah.
more complex
after-
anatomy.
he's gonna use now a polymeric wire to facilitate the entrance in the diagonal, just to do a provisional technique.
So we see here IVUS, it's a vessel about 3.25. And here, this is where very focal lesion, calcified, and doesn't appear to be a plaque extending to the
proximal of the-
osteon of the side branch. What makes us more comfortable
Okay.
to go with provisional stenting. And it's also myocardial bridging distal in the LAD.
So now we are changing the wire, change the IVUS catheter from LAD to the diagonal. Rodolfo is saying there are two reasons to predilate this patient. Because the lesion is severe by IVUS,
Yes.
so tight, and also there is a small amount of calcification.
You can see that's some negative remodeling. That's a nodule here about
Relógio. Fica ali, né?
3 o'clock.
Pra gente tá
Even though it does not compromise the lumen, but you might have some pinching of the also the side branch after you put a stent and have some carina shift here.
So what are you doing so far here, guys?
We just did the predilatation.
Predilatation with the 3 by 12.
Yes.
20.
20.
12.
12. I heard that.
Yeah.
12.
You're saying this. So it's what kind of pressure do you use? How much pressure?
10.
10 atmosphere. 10 atmosphere. Now we are going to bring back the balloon. All right.
Before.
What size of stent are you choosing?
Well, we are just we just
3.5.
did, yes,
3.5 by
12.
12.
Like
5 by
the
12. is
Like the
enough.
balloon.
balloon.
Okay. So you're trying to position
The length.
exactly where the balloon was.
Yes, perfect.
And I think here you can have enough space in the proximal part, at least 6 or 8 millimeters, to do the proximal optimization technique.
Okay.
That's important too.
This is a new stent that we are using here. We are using the Superflex Cross. That's the marketing. Where does this stent come from?
From India.
What type of stent is this one?
It's a
Cobalt
drug
chromium?
Yes.
Cobalt chromium, sirolimus.
Synonymous.
How about the polymer? Is it biodegradable?
Yes, I think the polymer free or false. I don't-
Okay.
So, Fausto, it does have all the features that these new stents have. So low profile, very good crossing profile. It's a wide range of sizes in terms of diameter and length, with a biodegradable polymer and sirolimus.
Okay.
It's a very effective drug.
So-
Bem grande.
Now we are deploying the stent. So the stent struts is about point 70, 75, something
yeah,
like
it's
this.
about that. Yes.
So, but you deploy the 3.5, and now you're gonna. Can you explain, Luis?
3.5 with a low pressure, eh?
I see.
Because the
8 atmospheres, and now you're gonna use a 3.0.
tirar o da DA. Peraí, deixa esse.
Yeah, I'm going to do. We have a little
There is
twist
some
here.
twist, yeah.
twist.
Yeah.
Okay, that's important. So when you are doing a bifurcation and twist can help.
Okay.
I mean, with the wire. What do you do to solve this problem?
We are trying to untwist.
Puxa um pouco.
Não
Right?
twist.
Yes.
Aí, segurei.
We're going to move back a little bit the guide wire from the
LAD.
LAD.
So you're going to cross again.
Yes. So we don't
Is there
miss.
any risk
Yes.
if you cannot recross or not?
Yeah, the risk is if we, because we didn't post the stand,
Uh-huh.
we can go behind the struts from the wall. So
Uh-huh.
that's we have always to think about it when you're trying to.
Now
do
you
this.
did that and you bring it back. Rodolfo, bring the wire back and recross, and now the balloon did okay.
Yeah.
Now we have a 3.0 by 12
Yes.
with a 20,
28.
wow, 28.
Ok.
28 atmospheres. 28 atmosphere 3.0 balloon, the distal part of the stand.
Agora, próxima
Now we're
parte.
going to bring it back and you do the pot with a
Tá comigo?
4.0 by 6.
4.0 by 6. So it's a larger balloon.
It's a larger balloon. You do all the work in the main vessel with provision, stepwise approach in provisional. You do all the work with in the main vessel, the stand.
Olha lá.
Then you're gonna recross to the side branch the wire, and you do what you have to do in the side branch. Not try to do this before.
Mhm.
Pra trás.
So this optimization is very critical.
This is a 4.0 by 6.
Yes.
How much pressure do you use?
16.
16.
It's okay.
To do the POT, the pot, proximal optimization. About that.
Yeah. So you see the result in the side branch. It's very good. I mean, it's no compromise.
Should we need to do to the bifurcation now to work in the side branch, or
Yeah.
can you leave it alone?
Yeah, if you leave it alone, you can leave it alone. But the evidence you have is that if you don't do a kissing, and kissing, you don't want to go high pressure.
Okay.
You just open well the cells and have the best geometry within the bifurcation. You're less likely to have restenosis.
Uh-huh.
And since this is a very large side branch, I think that's a good idea to do a kissing.
And then the
Just
other
have a good
advantage is
opening
to
there.
keep it open to future.
Keep it open, future procedures,
dois
good
pré.
access, and to avoid restenosis.
So that's
That's a reason.
a real demonstration of how to treat a bifurcation.
Yeah.
Now, what are you doing now, Louis?
We're trying to recross to the side
Diagonal.
branch here. the
Okay,
diagonal.
using the same wire that was in the diagonal.
No, the same wire that was in the LAD.
I mean the LED. I'm
Yes,
sorry.
Just
If you look at here, the wires are separated.
Pega o balão 3.
Yes, one wire is
Que usou na pré.
is the diagonal and the
the
LAD.
LED. It's over there. And now what are
First,
you?
we are come with the diagonal 2.5, 12.
2.5 by 12 balloon in the diagonal to do the kissing dilatation as Ricardo just explained
At
to
low
us.
pressure, at low pressure,
The reference was about 275 to 25. It's you should underestimate
Okay.
to some
6
extent.
atmospheres.
LED balloon, the 4.0 or 3.5?
3.0.
3.0 or
The
just
one they use for post dilatation.
just to.
The kissing show always size according to the distal reference.
So what pressure are you going to use, Rodolfo, in
Yeah.
both branches?
6 in the diagonal.
6.
And also some technical tip here: don't push back too much into the proximal segment, just enough to cover the osteons.
Diagonal primeiro.
Okay.
Diagonal.
Can you
Diagonal.
describe,
Just a little
please,
bit more.
Ricardo?
Yeah, so we're going here with the balloon in the osteo diagonal. We
Uh-huh.
have 10 atmospheres.
Uh-huh.
Just opening the cells here. You don't
Okay.
want to cause injury here.
Now you're going to bring back the balloon in the LED balloon
Yes.
Yeah,
and inflate both.
both markers all together.
Rodolfo is so precise and to have the balloons in the exactly position here, watching everything. So they are inflate both balloons with 6 atmospheres,
Ok.
8
Dois
atmospheres.
LED and
de insufle.
diagonal balloons. Now
And should
finish with the
deflate,
kissing.
should deflate together.
Maybe we're going to do maybe a small test just to see the flow, do IVUS and finish the
So-
second vessel.
So here you can also decide if you want to do a repot. A repot if you have length more in the proximal part,
Okay.
just to recover the circular conference here. Okay, so we are here in the distal to the stand in the mid LED. You see it's about 325 millimeter. We're still not seeing the stent here. It's virtual, just mild disease. And you see the very well optimized proximal part of the bifurcation.
And while you are going to the diagonal, and then you can say, so what are you doing now? Bring the ultrasound catheter, IVUS catheter, go to the diagonal branch.
So the 275 vessel, we come to the close to the bifurcation. That's a calcified nodule here. So I don't see any need to do some extra work here in this diagonal branch, even though there's some disease there.
Are you satisfied with the result, Louis?
Yeah, I'm pretty satisfied here.
Okay, good. So the IVUS is okay. Bifurcation was treated with a provisional stent in the LAD, doing port and everything. So we're going to take a look in the LAO.
Yeah.
There is a superimposed. So I think my IVUS is okay. Now we are trying to change the guiding catheter to the right and see if you have time to treat the both lesions that we showed you in the beginning in the right coronary artery. Rodolfo is still checking the LAD now in the spider view. That looks great. Now Louis is proceeding to exchange the guiding catheter.
Yeah.
Remember, we are working the radial, so we are in this ascending aorta. Bring the guiding catheter back, keeping the wire, the 35 wire, and now we have the RCA curve 3.5 or 4? 4? 4.
It's radial, because it's radial approach. It's the radial approach.
Radial approach, we use a 4. Now Louis is trying to catch the right coronary artery with the JR4 catheter. Let's see if it is possible. Okay, bringing it back. It's a little bit down. See, you can see both lesions.
Okay.
So should we go with a direct stent or also a predilation?
I think it's a bit severe to go direct here, folks.
Are you bring the stent or the balloon?
I think the balloon.
Balloon. We are going to predilate with the balloon 3.0.
2.5 by 12.
2.5 at 12.
Yeah.
Let's see. Let's do the predilation, implant the stent, and after we finish the procedure, okay?
Okay.
So we are predilating the distal lesion first. Now we are going to be proximal lesion.
Okay.
Good distal flow. Okay.
Let's do an angel.
Right.
A good predilation.
Yeah.
Let's take the test. Okay. Distal flow is okay. Now we are going to bring the stent distal 3.5 by 15. So Louis is bringing the 3.5. Now.
What stage tá aí já?
3.5 stent. The right position. Doing a test. Okay, just being concentrated. We are working fast, but with so much concentration to be in the right place.
Okay.
The right place?
Yep.
3.5 by 18 for the proximal right, and we are going to summarize the case and showing all angio images. Now the stent is almost in place. Yes, this is a 3.5 by 18 millimeter stent. Bring the guiding catheter a little bit back. Okay, good. Now we are deploy the stent in the right position. Yes. Last test. And you see that. Deploying the stent. What atmosphere we are now?
16. Okay.
Okay.
The contra angel here.
Okay, good. Can you show the... Okay, great. Great result. Rodolfo, can you show us the first image there and while Louis is working on there? Could you please look at there? So you have now the circ that was treated by the long stent. Can you show the stent? That was guided by IVUS. Final result. Now we went to the bifurcation, post-dilation. Final result in the circ. And now we go to the LAD bifurcation, and we treat both with a stent in the main vessel, provisional in the diagonal, with also good result, guided by IVUS, and we went up to the right. So we used maybe 150 cc of contrast in this patient. So this is the right, two lesions, proximal and distal, multivessel, and finish. We place standing LAD, circ, and right, and after we treated the aortic stenosis in the other lab. So thank you much, and we are going to see you the next week. See you later.
See you.
Bye-bye.